But okay. We'd like to start a topic by name with title Congenital Anomalies of the Larynx. Under this heading, we can see the embryology of the development of the respiratory tract, which includes your larynx and also tracheobronchial tree. The larynx develops from the fourth and fifth bronchial arches. At the third week of gestation, the respiratory primordium is derived from the primitive foregut to later form the lung bud and later the bronchial bud, which will eventually develop into the tracheobronchial tree. It will develop from the ventral surface of the foregut. At the fourth and fifth week of gestation, the tracheoesophageal folds fuse to form a tracheoesophageal septum, leading to the separation of the tracheal airway lumen from the esophageal digestive tract. So, any sort of failure in this sort of steps or even developments can lead to congenital anomalies. So, after looking into the embryology aspects, we can easily interpret what could be the reason. If so, what are the possible symptoms and signs and leading to other complications. And later on, we will go to their management one after the other. So, this is the diagrammatic representation. You could see the foregut and yellow tube-like. Ventral aspect of it is respiratory diverticulum, and later on there is a tracheoesophageal septum forms. Later on, both fuse, and finally there will become a partition between esophagus and trachea. In the case of routine, there will not be any communication between airway and food passages. It is completed by means of by period of organogenesis by 4 to 6 weeks. So there are some sort of congenital anomalies possible, that is called tracheoesophageal fistula, leading to some types. So out of this 1, 2, 3, 4, the 4 types have been described. So when we really come to the topic proper, we will read in detail. So before that, we have been in a position to know what are the difference between adult larynx and pediatric larynx. The very important aspect. Usually, it determines why the pediatric airway is different from adult airway. So the newborn larynx is about one-third the size of the adult larynx, and the diameter of the subglottis and glottis are narrower, when which leads to increase in propensity for airway obstruction and compromise. The subglottic region is about 4 to 5 millimeters in diameter. The epiglottis is also narrower in infants. The larynx lies at the level of the third and fourth vertebra at birth. By 15 years, the larynx descends to the level of sixth vertebra. The dimensions leave a little margin for obstruction in the infant, unlike the adult. The narrowest portion of the airway in the older child and adult in the glottic aperture, that is in the Ramakrishna. While the narrowest portion of the airway in the case of infants is subglottis. This is a very important aspect we have to keep in mind. The diameter of the newborn child of the subglottic area is 4 millimeter, and the lower limit of normal in full-term infant, and it is 3.5 millimeters in the case of premature infant. Indeed, the infant with a 1 millimeter subglottic edema can experience 35% of obstruction of the airway. It all depends on the circular structure. Pi r square is the area formula. That's why 1 millimeter is enough to reduce the 35% of the total available area in the case of tubular structures. That really has got a greater effect when lead to obstructive pathology. In subglottis, 1 millimeter of circumferential edema leads to over 60% of the narrowing. We got a lot of significance. What are the clinical manifestations of the congenital anomalies? So it is very easily interpreted or understood. What are the possible? One is respiratory obstruction, which will lead to stridor, that is noisy breathing. And next comes is weak cry, because of the what about speech mechanism you'll get a weak right impairment. Next comes is dyspnea, that is nothing but a respiratory embarrassment. Tachypnea, when the respiratory embarrassment is there, because your respiratory rate increases, that is otherwise called as the tachypnea. So later on, aspiration is one of the things. It all depends on the various congenital anomalies, especially so with tracheoesophageal fistulas. And cyanosis is the end result of the chronic hypoxia. That means blue baby. So thereby, hypoxia lead to this sort of bluish discoloration. It is the sign of hypoxia. Ultimately, a stage will come. If it is not revived or improved with oxygenation, child will go for sudden death. These are the ultimate consequence of respiratory embarrassment. The clinical presentation of each lesion varies from the site of abnormalities what is resulted. The major current lesion presented with the symptomatology in the neonatal period or during the infancy. So, these are the few things you have to keep in mind. It may be within 1 year or later on also possible. So, laryngeal lesions typically present with a stridor, very noisy breathing, portions of voice that is nothing but a some sort of vocal cord palsy or something like. Aphonia is the one where child cannot produce sound and possibly feeding disorders, depending on the connection between airway and food passage. Stridor is usually inspiratory or possibly biphasic in nature. Majority of the time it is inspiratory. Stridor is different from stridor in the primarily caused by any obstruction above the level of larynx. There may be the problem in the nasal or if not pharyngeal regions also. So you have to keep in mind the difference between stridor and stridor. Thereby you can localize the lesion accordingly we have to address the problem. So let us look into some of the abnormalities. Just now it is informed to you. Supraglottic abnormalities, glottic abnormalities, and subglottic abnormalities can be broadly classified. What are the supraglottic abnormalities? In this, one of the classical findings is your laryngomalacia. Later on, you will get some sort of problems like cysts and other things will go one after other. So let us move on to the next commonest cause is laryngomalacia. It is one of the commonest cause or congenital anomaly in infants or newborns. It accounts to the 60% of the laryngeal problems in the newborn. It has been mentioned as boys are more affected twice as often are girls. It is usually self-limiting condition, but when severe, it may produce problems which will lead to life-threatening obstructive apnea, carpulmonary, or failure to thrive. Fatal outcomes have been described. Severe cases may require intubation or tracheostomy to secure airway. Airway maintenance is ultimate requirement. Intubation is the preferred choice. Really, tracheostomy is to be last choice to prefer. Some surgical procedures have been mentioned. So after that, the upper picture shows normal larynx. The lower picture shows classical laryngeal inlet in the case of laryngomalacia. So what are the changes? What we are able to identify? One is the shape of epiglottis itself is not normal. It is mentioned as a omega shaped epiglottis that is laterally compressed. Thereby, you can why it is happening is because shortened hairy epiglottic folds will pull the epiglottis towards the closer side. Both the hairy epiglottic folds are shorter. Thereby, laryngeal inlet is reduced in size. Almost folded epiglottis we call it. It will lead to appearance as a tubular epiglottis with posterior collapse. And the supraglottic structures are pulled into the lumen around the vertical axis with inspiration. Because of the weak cartilages is the reason the child usually gets comfortable when the child sleeps in a prone position. So that is one of the counseling or technique we inform mother, whereby child will improve without much of problem. We will put the child on calcium and vitamin D preparations along with the sort of counseling. As the child grows, condition improves. Usually, we don't recommend tracheostomy as the first line of choice. Endotracheal intubation may be thought, but it's also can be possible to prevent the hypoxia or cyanosis, whatever it is. Condition arises from the continued immaturity of the larynx. That is one of the things you have to keep in mind. And as the child becomes older, the strength of the laryngeal cartilages will be increased. The collapse will not be there, thereby airway patency will be maintained. Later on, abnormality appears to be flaccidity or incoordination of the supralaryngeal cartilages, especially the arytenoids, that is expressed when the infant is stressed by excitation or crying with increased respiratory rate. Stutter is typically noted in the first few weeks of life and is characterized by high-pitched inspiratory sounds and fluttering. Therapy consists of the confirming the diagnosis by means of doing a laryngoscopy. We prefer to do flexible laryngoscopy and reassuring the parents. I just happened to tell you as counseling, and the prognosis of the child is favorable. The nutrition status, everything will be improved, and child is asked to take the prone position. Thereby, collapse will not take place. Position changes of the infant may help alleviate the stridor, and it typically worsens the supine position when the child takes a supine position. In the past, tracheostomy was a surgical procedure of choice. Many cases used to be undergo this. Now we are not taking as a first line of treatment. And we got some surgical techniques that is called supraglottoplasty has proven to be successful for the correction of the supraglottic obstruction, and it is now the surgical procedure of the choice. It consists of see the one clinical pictures showing that patient undergone uh, supraepiglottoplasty. We use laser, whereby the epiglottic folds, which are shorter, are vaporized, thereby scarring takes place. Gradually, the length of the epiglottic folds increase, thereby the closed epiglottis will become open, thereby patency is restored, child will be condition will be improved, stridor will be reduced, child feels better. In addition to that, as the child grows, the strength of the cartilage will be increased. Child will get total benefit of patent larynx. This is called supraglottoplasty. Sometimes we can even excise the collapsed epiglottis also. Next condition we come across is laryngocele. It is nothing but a dilated sac filled with air, and it is been subdivided into internal and external laryngocele. May present at birth, that will lead to stutter, and it is difficult to diagnose. But CT may be of use, but having a question mark whether how far it is going to be possible in that age group. And next comes is we go for endoscopic procedures or open procedures to solve the problem. And the recurrences are quite low, and this is easily manageable by using endoscopic techniques. And the laryngoceles are within the larynx itself. They don't cross the thyroid membrane. When it is limited to insert, it is called internal laryngocele. External laryngocele penetrates the thyroid ligament or membrane and the neurovascular bundle. Mixed laryngocele means both internal and external components are there. It is like a dumbbell, and thereby we have to treat accordingly. And in the case of adults, professional mm, so-called glass industry workers, they use blowing and other things. They get some sort of occupational hazards can be taken as the one of the factors to develop laryngoscopy in that age group. Treatment. These are the rare infants and can cause intermittent hoarseness and dyspnea that increase with crying. Diagnosis may be difficult as these can be contrast and may be visualized under the anesthesia. The CT may be visualized valuable in these instances. Endoscopic and open procedures have been advocated depending on the size and location of the larynx. I just happened to tell you it has got a intrinsic and mixed and extrinsic laryngocele has been subdivided and classified. Another abnormality we come across is related to glottis. So in this, we got a glottic webs and your abductor palsy or vocal cord pulses are possible. After that, we have laryngeal webs is seen. It is described, and it is probably because of failure of the recanalization of the larynx. And many of the times, or 75% of the total laryngeal webs found to be at the glottic level. The most anterior with subglottic involvement is noticed. There are four types with increasing severity, were present at birth and it can be diagnosed with flexible laryngoscopy. Airway films helps with subglottis. Helpful for subglottis. The presentation of the laryngeal webs varies with the severity and type of the webs. Laryngeal webs have been classified four types: type 1, 2, 3, and 4. Type 1 laryngeal webs involve 35% or less than the total cases. The two vocal cords are visible through the web, which is thin membrane, and there is a little or no subglottic extension. So symptoms include the mildly abnormal cry with some hoarseness. Respiratory distress is usually not a very prominent. It comes to the type 2 webs or anterior webs involving 30 to 50% of the glottis. Subglottis involvement stems more from thicker anterior webbing than from cranial abnormalities. Airway symptoms are uncommon except during infection or after intubation trauma. Sorry. Type 3 webs involve 50 to 75% of the glottis. So the web is thick anteriorly, and the two vocal cords may not be visualized, and that itself shows that it is thick web and more of a tough tissue. They may be associated with cricoid abnormalities. Airway symptoms are often very severe, and marked vocal dysfunction can happen. The type 4 webs occlude 75 to 90% or more of the glottis. It is uniformly thick, and the true cord is not really identifiable. The patient is aphonic, and immediately airway management requires, in this case, to intervene. To get a good quality of life. What is the treatment available? Thin membranous type 1 webs, which produce only minimal symptoms and can be observed until age of 3 and 4 and divided with either carbon dioxide laser or cold knife. The type 2 webs can be managed by cold instruments by incising the web along with vocal cord and then proceeding with the stage dilatations. Probably we use sort of pneumatic dilatation. Treatment of type 3 and 4 webs is usually delayed until the child is 3 to 4 years old. Most infants will have a tracheostomy in place of airway control until definitive surgery is undertaken. And the standard treatment for these conditions entail tracheotomy, that is otherwise laryngotomy also can be thought of, and keel insertion, that is inert material between the two vocal cords, and it will be fixed. Once the healing process takes place, the keel can be removed in course of time. So next comes is congenital vocal cord paralysis. This is the next common situation following your congenital laryngomalacia. Vocal cord paralysis has long been recognized as a significant cause for stridor and hoarseness in infants and children. It is the second most common cause of stridor in the newborn after laryngomalacia. Laryngeal paralysis may be present at birth or may manifest itself in the first month or two of the life. The neurological impairment reflects an injury to the vagus nerve. Probably birth injuries can give rise to sort of presentations. You can see in the pictures. One is Barrett abdominal palsy. The glottic chink is very, very minimal, and the other one probably it is unilateral vocal cord palsy. Adequate, reasonable glottic chink is available. The suffering of the patient is more with bilateral palsy. Both cords are in adduction, whereby the airway is practically minimal. Child will be having a struggle for breathing, and the quality of the speech may be good, but struggle for breathing on exertion will be there. The lesion can occur anywhere starting from brain down to the neck, into the chest and into the lung. Many paralysis are idiopathic up to 40% of the cases. The most common causative factors include conditions such as Arnold-Chiari malformations, hydrocephalus, neonatal hypotonia, multiple peripheral paralysis that is otherwise myasthenia gravis, and other causes include birth trauma and cardiac anomalies. Associated laryngeal lesions such as clefts and stenosis are also commonly often found. The other side, on the lower part of the frame, is a child with tracheostomy, so thereby the straddle is relieved. Child is a little bit comfortable when compared to earlier situation. What are the symptoms? Any or all of the normal laryngeal functions may be abnormal in pediatric patient with laryngeal paralysis. The most common symptom is stridor, that means noisy breathing. Ineffective cough, aspiration, recurrent pneumonias, and feeding difficulties are also commonly reported. Consistent stutter, cyanosis, and apnea are very much frequent. Voice and cry, however, may be normal, particularly in cases of bilateral palsy. I just happened to tell you earlier, the child quality of this speech, or if not voice, is reasonably better, but the main problem is with airway, that is breathing. That means patient will be having struggle for breathing, but speech will be not. A better speech. Hoarseness of voice and dysphonia are common in cases of unilateral vocal paralysis. Child will not be struggling so much. Sometimes it will go unnoticed. So thereby, stridor will not be that much. Child will adapt. So thereby, child can have a relatively comfortable life than bilateral palsy. Bilateral palsy is an emergency. Management of situation depending on the child underlying condition. Child with bilateral palsy frequently requires surgical intervention. I just happen to tell you, struggle for breathing will be there, but voice quality may be reasonably better. So the maintenance of the airway is prime requirement. That's what surgical tracheostomy is must. Airway is often markedly compromised, and over 50% of the cases, tracheostomy is required. Sometimes we take it as an emergency. We need to be prepared to do that. Especially in the case of pediatric tracheostomy, we should be very careful. Otherwise, while doing aggressive handling, can lead to even pleural injuries, leading to your sort of air locking and all sort of things will take place. And you have to distinguish trachea from the radial vessels. Emphysema is again possible in those sort of cases. Pneumothorax is also possible, but there are the few things you have to keep in mind while taking the tracheostomy. The procedure of tracheostomy is also a little bit tough in case of children. Multiple radialization options include CO2 laser cordotomy, and often and we need to do open arytenoidectomy, arytenoidopexy, arytenoid separation with cartilage grafting, or laser arytenoidectomy or cortectomies can be planned as per the availability of the infrastructure. The management of the unilateral vocal cord palsy in children usually less urgent. I just happen to tell you, child will tolerate the situation. Airway is not so vastly reduced, the child can adopt. Then bilateral abdominal palsy. The children adjust well with the persistent unilateral abdominal palsies with a few sequelae. The weakened cry may be result, but adequate airway is typically maintained. Some aspirations may be possible in the case of unilateral abdominal palsy. But the overall struggle for breathing is not as in the case of bilateral abdominal palsy. The next one is your subglottic stenosis and some subglottic abnormalities. Under this, we got subglottic stenosis, and you got a laryngeal clefts. We will deal one after other. Number one, out of the subglottic area problems, one is subglottic stenosis. It may be classified either acquired or congenital. Although the congenital subglottic stenosis is uncommon, it constitutes around 5% of all cases. It is the third most common congenital anomaly. The first being your laryngomalacia, second being your vocal cord paralysis. The third one is this entity, that is subglottic stenosis. Congenital subglottic stenosis is thought to be secondary to failure of the laryngeal lumen or luminization or recanalization properly during embryogenesis. Subglottic stenosis is considered congenital if there is no history of endotracheal intubation or other forms of laryngeal trauma. Subglottic stenosis is defined as a subglottic lumen is less than 4 mm in diameter at the level of cricoid in a full-term infant. The normal newborn subglottic diameter is 4.5 to 5 millimeters, and in the case of premature neonates, it is 3.5 millimeters. Congenital subglottic stenosis is divided histopathologically into membranous and cartilaginous type. Membranous subglottic stenosis is usually circumferential and consists of fibrous soft tissue thickening. Cartilaginous type is usually result from the thickened or deformed cricoid cartilage, especially of lamina of the cricoid cartilage. The severity of the congenital subglottic stenosis depends on the degree of the subglottic narrowing. Children with subglottic stenosis usually present with stridor or respiratory distress or otherwise respiratory embarrassment. The classification is already been put forth. The McCaffrey system classifies laryngotracheal stenosis based on the subsites involved and also the length of the stenosis. 4 stages have been described. Stage 1 lesions are confined to the epiglottis or trachea and they are less than 1 cm long. Stage 2 lesions are associated with subglottis and which are greater than 1 cm long. Stage 3 are subglottic and tracheal lesions but not involving the glottis. Stage 4 lesions involving the glottis. These are the few classification depending on the length of the stenosis segment. Treatment of congenital subglottic stenosis tailored to the situations and also symptoms and the grade of stenosis. Symptoms are typically less severe in congenital subglottic stenosis than in acquired form. Congenital subglottic stenosis also improves as the child grows, and less than half of the children with this disorder will require tracheostomy. For those children who don't require surgical intervention, several options have been put forth and they are available and to be considered. Mild stenosis, as per the Cotton-Mayer's grading, 1 and 2 can usually be treated conservatively. It are circumferential diameter, not length of the stenotic segment. It can be treated conservatively with observation. In case that do require surgery, endoscopic techniques such as carbon dioxide laser resection of the membranous web can be performed. Grade 3 and 4 stenosis may be needed some form of local surgical procedures, as is typically or the result of cartilaginous stenosis. Next comes is your laryngeal cleft, which is a rare congenital anomaly. Congenital laryngeal anomaly occurs in 1 in 2000 live births, that is less than 0.3% attributed to laryngeal cleft. Boys, girls, the ratio of 5:3. Contributing factors is already informed you. There is nothing but a prematurity and hydropneas. So this is the some pictorial representation. Cricoid cartilage begins forming at 5 weeks of gestation and derived from 6th brachial arch. Contrafication completes by 6th week. That is 5th to 6th week. Developmental abnormality can give rise to the clefts of the laryngeal cleft. Incomplete fusion of the tracheobronchial septum or cricoid cartilage leads to laryngeal cleft with the tracheoesophageal fistula. These are the pictorial representation of the types of laryngeal clefts. And type 1 cleft is supraglottis, intrarythmoid clefts. Type 2 clefts are partial cricoid cleft. Type 3 clefts are complete cricoid cleft with or without extension to the esophagus. Type 4 cleft are full laryngotracheal esophageal clefts. So with this classification, we can go with a appropriate treatment. So type 3 and type 4, they are going into the thoracic inlet. So what are the manifestations? It is easily interpreted. It is nothing but a communication between your airway and food passage. So leading to choking, aspiration while taking feeds. And there is a possibility of regurgitation as well. And there is a possibility of stridor. And when there is a regurgitation, finally leads to aspiration. In turn, can give rise to recurrent pneumonia. And there is a possibility of chronic cough. When it go to the extreme, child will have cyanosis, probably leads to death. What is the treatment available? Timing and approach for surgical repair depends on the severity of the symptoms, associated abnormalities, type of the cleft. In small cleft, conservative positioning and thickening, thickened food, not liquids, may be tried. If surgical repair is failed, you can think of doing a gel form injections as an alternative, and later on, open approach for graft insertion, interposition. Next comes is this can be done by endoscopic approach.